Good evening. Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and founder of Above and Beyond Cancer. Welcome to our Cancer Education Series, which is brought to you in part from a grant from the Iowa Cancer Consortium. And I've got a friend of mine here tonight. Hey, Erin.
Hello.
So this is Erin Sullivan Wagner, and believe it or not, we went to high school at the same high school. We grew up in the same town in South Dakota, and then didn't see each other for about 40 years, and at a cancer talk, kind of ran into each other again.
That's right. It's nice to be here. Thank you for having me.
So Erin went to Madison High School, Madison, South Dakota, then became a Hawkeye, went to the University of Iowa, and we're going to learn a bit about her cancer journey, and she is the founder and president of After Cancer, a solution for sexual health, and has created a wonderful program called All of Me. And we're going to talk about the importance of sexual health for cancer survivors.
Sounds great.
So welcome.
Thank
you.
you.
I think maybe we should start by why you got interested in sexual health for cancer survivors, and
Sure.
maybe share with us your cancer journey.
Okay. So it goes back to 2008. Farrah Fawcett and I had cancer together. For people that are old enough, they care about that. They can take themselves right back there. And I had anal cancer, no surgery, had chemo and radiation for 5 weeks. You know, survivable cancer. And so I was really not too concerned about how things would go. I was told at the very beginning I would have no sexual health issues from my treatment or the cancer, and that I was young, healthy, sexually active, nothing to worry about. And come to find out, there was everything to worry about, but it really had to do with not being treated in a timely manner. So after that all went down, which took years, but you know, within a year or two, I realized.
Well, before we talk about the side effects, some people may not be as familiar. So, anal cancer is cancer of the anus, and the anus is the last, basically inch or two of the rectum before the stool would come out. And so anal cancer is cancer that begins down at the anus, and as Erin said, treatment used to be years ago. You would remove the anus, and somebody would have to have a colostomy. One of the big advances in anal cancer is we found we could cure it with chemotherapy and radiation therapy without having to have the person have their lower rectum removed and have a colostomy. But that involves weeks, months of chemotherapy, and weeks, probably 6 weeks of radiation therapy to the pelvis. That includes the uterus, the ovaries, the rectum, the bladder, the skin of the anus, the vagina. So just to put it in perspective.
Yeah, and that's all. I'm glad you did.
Is one of the tougher treatments. Not only are there lots of side effects while you're going through the treatment, where you sort of get over those, but then there's the lingering side effects that develop over time.
And this is a little bit off topic, but we really do believe that the cancer was caused from HPV. So,
Yes.
and that's very common. So that's good to know too. Had we been having Pap smears, anal Paps back in the day, maybe would have caught that like you would have with cervical cancer.
One of the 6 cancers caused by HPV. So most of the public probably knows about cervix cancer caused by HPV, but in women, vaginal cancer, vulvar cancer, which is the skin around the vagina, and anal cancer also caused by HPV. So hopefully, with everyone getting vaccinated, and right now, our vaccination rates for HPV are not as good as they could be, but that this is a preventable cancer. And anal cancer can also occur in men due to HPV. And for those who are counting, I've named off 4 of the HPV cancers: cancer of the penis and cancer of the oral pharynx, the back of the throat, are the others. So HPV caused cancer.
Yeah, they believe so. So even though I didn't have HPV at the time of cancer, they believe that it was caused from that years and years ago. So that's just a by the way, but I think it is interesting to note that. And with, I was a first-time cancer patient in 2008, so I didn't really understand. I had never heard of anal cancer, so that was, a tough word to say anyway, and to ask many questions about it, so it probably stifled me a bit just because of that. But when I was told that I would have no sexual health issues because of it, honest to God, I thought, because I have anal cancer, do you think I have anal sex? And am I not going to have any sexual health side effects related to anal sex? Because I don't care. I didn't know even what they meant by you'll have no sexual health issues.
And at the point you were diagnosed, at what age were you?
I was 49.
And in a strong, good
Yes, married.
relationship,
Yes,
marriage
yes,
and
yes,
sexual relationship.
yes, and really didn't have HPV at the time. I mean, there was really no concern about anything regarding fidelity, but that is a whole nother topic that people get into when they realize they have an HPV cancer. There is the question of, okay, who gave that to me? Did you give that to me? There's that is a complication for people too. But when I was diagnosed, it's the last thing on your mind, really, that you might or might not have sexual health issues. And I thought I didn't know what they were talking about anyway, because I had anal cancer, and so I didn't understand why I would have sexual health issues, but I didn't care. I really wanted to survive the cancer. So it was easy for me to think nothing more about it. And they said nothing more about it until 6 weeks after, just said it was good, just like having a baby. You're healed, you're good, you can go ahead and have sexual activity again, including penetrative sex. And that was so far from true. I could not, and didn't know it until we tried, and the pain was so urgent and severe immediately that there was no way to hide the look on my face, the grimacing in my body, the tears, it was just horrible. And that, every time we tried, that was the result. So I knew something was really wrong, and I went back to my oncologist. And of course, I didn't know what was the problem. So I went back to my next appointment, which was medical oncology, and they were like, yeah, it's not our problem. It'd be radiation. And so went to the radiation oncologist and said this, and they said, we haven't heard about this before. So I felt like an anomaly, that, oh, okay, so something's wrong with me here. And then started they eventually referred me to my gynecologist. But in that time period, I was diagnosed in January, and I was referred to my gynecologist in August. So treatment for the first time to remove scar tissue in the vagina was done in September. That time period was the cause of the real problem, which was the hymenal ring had no elasticity because the scar tissue had built up at the opening of the vagina. They never did figure that out until the very end. So all of the treatment, all of the possible cause of it, let's try this, and rehabilitation therapy and dilators with estrogen cream and vaginal suppositories and lidocaine and Xanax, and just they threw everything at making the pain less and hopefully stretching myself enough with these dilator tools to the point that I would take a dilator tool, which is like a test tube, looks like a test tube, but they're graduated, and I would insert that inside of me, and I was told to put pressure on it.
Inside your vagina.
Right. Put pressure on it. I would do this for 5 to 10 minutes. Put pressure on it enough that I'm stretching the opening. It would stretch to the point it would bleed. It was torn open. And then the goal was to have it heal torn open so that it would be larger in size. But raw skin like that, you can only imagine having something rub across raw skin, broken open sore. There was no way you could live through that kind of pain to ever keep it open, unhealed. So it was, I chased every treatment I could chase until really it was 8 years later that they just called it and said, I'm sorry, but you didn't get treated soon enough. The scar we just can't do anything about the scar tissue.
So a little bit about the physiology of what happens. So when a patient is getting chemotherapy and radiation therapy, while you're getting it, there's lots of inflammation. Things just get swollen and inflamed. I mean, looks kind of like an infection. It's red and swollen. Then when that subsides after you're done with the chemotherapy and radiation therapy, things may kind of look normal on the outside, but what happens with the radiation effect on all the tissue, obviously the radiation played an important part in curing your cancer, but the tissue that got irradiated wasn't just the cancer cells.
Right.
It was the vagina, it was the uterus, it was part of the bladder, it was part of the rectum, and then as that heals, the tissue becomes scarred or fibrosed. So normal tissue is very elastic. It stretches. I mean, you can imagine the vaginal canal can stretch to be big enough to allow a baby to come through it. So it's normal tissue stretches. Tissue that's been irradiated becomes dense and doesn't stretch. And the longer you go without stretching it, the more densely fibrotic it becomes, and it becomes harder to get it to stretch. So as Erin was pointed out, an important part is that once you finish the radiation and the chemotherapy, you provide a woman with dilators and lubricants to start, okay, even if you're don't have a sexual partner right now, it's important to stretch, keep the vagina open so that when things finally do heal, you've got a large enough opening that you're going to be able to successfully continue to have penetrative sex.
And not even just for sexual health, but for vaginal health.
Yes.
You'd want to keep so it was surprising to me that there was no expectation set that I should care about this. I was just told that there would be no issues. And when I went back, they said they hadn't heard of it before. That was crazy talk to me, but I then took life coach training and became a life coach. And at the time, I really thought that the coaching I was going to do for patients was going to be around that, all of the emotional journey that we all go through as cancer patients, just things you never thought, the fear of recurrence, just the wanting to have meaning in your life. I thought that's what I was going to do. And when I talked to patients, it was difficult for me not to say, did you have any sexual health issues from your cancer treatment? And almost unanimously, they said yes. And next question, did you talk to your provider about it, or did anybody bring it up to you? Almost unanimously, no. It had never been addressed or resolved. So then I changed gears and thought, I need to talk to patients about this. I need to help patients talk to their providers about this. That's where I need to be. And before too long, I realized I really thought that I needed to be a voice of the patient, and I needed to go back to the oncology community and say, you've got this wrong, just on behalf of all patients who may want to have that part of their life restored, because we all assume we're going to have that part of our life restored. We're curing cancer these days, but we're left with the side effects of those treatments. And
one thing you said that I just wanted to touch on, because as you said, you were going to deal with the patients. We're going to empower the patients. So you empower the patients, and they go to their doctor and they say, "No, we never heard of it.
Yeah.
We don't cause
Yeah,
any
that's not
sexual
gonna be an
dysfunction."
issue. Yeah.
So you can empower the patients all you want, but if you're left with providers that either through the same embarrassment everyone naturally has about talking about sex, you empower the patient, but the provider isn't open to having the conversation. So you quickly realize that you could do greater good, not just by empowering patients, but by educating
That's
the
right.
caregivers.
That's right. Just first of all, I think that I took a year or two and we just raised awareness about it. So I collaborated with menopause and sexual health medical director at the University of Iowa and a reconstructive urologist to give the men's side of things. And these two physicians and myself kind of went on the road with this presentation to oncology nursing. We thought we'd start there because the nurses, we thought people connect with nurses maybe at a deeper level more often than they are able to with their physician who was only 7 minutes. And
Right.
my 7 minutes is going to be used to talk about my cancer, so we targeted oncology nursing to raise awareness there that their patients really do need them to care about this and to talk about it. And then branched out from oncology nursing to include most of the patient care team. So radiation therapists, mental health therapists, social workers, nurse navigators, sometimes medical assistants, just anybody that interfaces with that patient.
And back to as you started talking to patients, you learned, you were told, boy, you're like the only one that's ever had this.
Right.
And you learned that no, like 100% of patients that get treated in the pelvis have issues.
100% in the pelvis. That's exactly right. If
100%
you've got,
of the pelvis.
Yeah.
And then probably, at least 50% of breast cancer patients.
Sure. So overall,
And then probably a certain percentage of all patients, dealing with
it's over 50.
when you look at the psychological, philosophical, along with the physical effects that happen.
And that is such a good point because this isn't just sexual function that we're talking about. So in my case, there was a sexual dysfunction, but for some people, there is just stress and anxiety and fatigue and depression, and there's all this other that goes along with sometimes the hormonal changes because of the treatment that isn't necessarily sexual function, but still impacts the patient in the same way.
And then, as you already mentioned, along with the fear and anxiety and all of that just deals with all intimacy problems.
Right.
So when you include that whole aspect, then it doesn't really matter where your cancer is. Sexual intimacy and sexual health is something we should address. But it kind of started with it absolutely when it comes down to the physical and the mechanics. If you're getting treatment to your pelvis, and it's including radiation, you will have sexual dysfunction as a side effect.
That's right. And actually, though, all patients, over 50% of them have sexual health issues from their treatment, and less than 20% of them are ever addressed.
Mm-hmm. So you learned that from your patients. What else would you say you learned from your patients before you you learned, that the doctors and the nurses don't offer to talk about it spontaneously, and that even if you bring it up, they may not feel comfortable talking about it?
Right. So we call it the communication gap, and it's real. There are reasons that providers don't talk about this with their patients, and there are reasons patients don't either. And what we learned through my work with patients, but then focus groups with providers, really what that communication gap's all about. And from the patient side of things, this is the most vulnerable I am ever going to feel in my life. Something I thought I had control of my body, cancer appeared. I had no warning of it. I had no control of it. It was the last thing on my mind to think that I was going to control everything else. It's just, I think probably the most vulnerable place patients are is with a cancer diagnosis. So we look to our providers. Patients really do look for guidance. There is this God complex that we give oncologists. We need them to tell us what to do and what not to do, and we follow that to the letter, the perfect patient. You've heard of that? That's all so true. If you're my physician, I will do what you tell me to do, nothing but what you tell me to do. And if you don't tell me that should matter to me, that shouldn't matter to me. You'll tell me when that should matter to me. Just like you tell me when things are going to impact my bowel function or incontinence, my quality of life issues, you'd tell me. if it's a quality of life issue. So patients assume that their healthcare providers are going to care about all of them, and not just today throughout this cancer, but any impact that my treatment might have on me. We assume that as a patient, but it's a bad assumption.
Right. Yeah, healthcare
Or so we found out.
has let you down, and lots of other patients.
And one other thing, sometimes we aren't sexually active during the treatment, or we're not with a partner right now. We may not know that we've got sexual health issues. It may not be obvious to us. So it's another reason why it really the patient really needs that expectation set, because they may not know to even be concerned about it.
And maybe talk a little bit more about, as you then started talking to healthcare providers, doctors, nurse practitioners, nurses, all of the healthcare. What did you learn about healthcare workers' willingness or lack of willingness to have conversations about sex?
So I think there is a willingness to want to help patients in any way possible. From the start, that's where a lot of the patient care team members were. But they have had zero training talking about this. They have been given no words, no script, and in some cases they are afraid that that patient will be offended. They have to make some assumptions. And what if the patient isn't alone? What if the patient has their 5-year-old child? There's all these reasons why it's easier to turn a blind eye to it as a provider.
Yes, and you sort of one philosophy to sort of an excuse is, well, if they want to know about it, if the patient wants to know or is interested, they'll ask.
Absolutely.
If they're not asking about it, maybe they're not sexually active. Maybe they would be embarrassed to talk about it. Maybe me bringing it up is an embarrassing thing. And there's all sorts of excuses. Everybody in the room. And how do you become good at doing something? You do it all the time.
You do it all the time.
As an oncologist, I would have to say I was never truly trained at how to talk about death and dying and approaching death, and you don't get good at that unless you are willing to have those conversations and be in a room and talk about that. The same thing with sexual health. If you never talked about it, you're not going to be comfortable the first time or the 10th time, but by the time you get to the 50th time, and then having an organization like we're going to talk about, where you train folks to know, how do you have this conversation? What are the words? How do you begin, having a genuine, authentic conversation where you put someone at ease, and in the process you learn about their intimacy. Do they have partners? How important is the physical act of intimacy? Where does that fit into their life in terms of importance? It's probably easier to get into the conversation when you're treating a woman for cervix or vaginal or anal cancer, or you're treating a man for prostate cancer, where the sexual organs are part of where you're doing the treatment. It seems easier to open it up to that conversation. If I'm treating someone for a brain tumor or a lung cancer, it may be I might think that the patients, why are they asking me about my sexual health when they're going to be treating a tumor in my right upper lobe of my lung?
And for sure, and that's a really good point. So generally speaking, all patients that have cancer surgery, or go through cancer treatment, it's an appropriate thing to bring up. Because as we said before, it isn't just sexual function, but it's so many of those side effects that actually do impact your sexual health, like the anxiety, depression, fatigue, all of those things too, which you would get with any of those cancers. If you know the area, that area is going to be difficult for the patient. You can speak right to that. But what we learned when we started doing these workshops for groups across Iowa is we learned that they really needed, now these are mostly
Let me just
oncology
clarify,
nurses.
yes,
Okay.
that your workshops now are not for patients, they're for providers,
Right.
for people in the medical world. So as you then develop the program, All of Me, and we'll talk about it, you realize that you could have the greatest impact by talking to the people in the healthcare world, the oncologists, the medical oncologists, radiation oncologists, the nurse navigators, the people who interact with the patients.
That's correct. And we first understood what are the barriers? Why aren't you doing it today? There were some really good reasons that they weren't doing it today, overburdened clinics too, but there were good reasons. But part of it was that training.
Yeah.
So everything we learned from those groups.
So you
we
started,
developed.
and before I interrupt you started to talk about what did you learn when you started doing these workshops for the medical care providers.
Right. So what we thought we were going to do is they were, by the time this workshop was over, they were going to know how to talk about sexual health with their patient. They were going to be able to set patient expectations and have a good idea of when to refer patients out. That was way too lofty of a goal. What we found was people wanted a script. They wanted to be able to tell without having to get into a sexual history. We don't have time, right, for a sexual history anyway. I don't have the education to take a sexual history. I'm not comfortable doing it. But I can give a 30-second message. I can give you as a patient a 30-second message about what to expect and what I know about the relationship between sexual health and cancer. And that is what we expect everybody to do. It's so vanilla. You can give it walking down the hall. You could give it with a 5-year-old in the room. You could give it with just somebody who accompanied the patient. It has 6 components to it, and we got comfortable with those providers, and they ranged from all of the patient care group, mostly just not the physician. So everybody else, they got very comfortable learning what are those components of this message.
So what are the components?
So sexual health and cancer, they're related. It's common and expected. And it's a quality of life issue. We believe that. So this is all part of normalizing the conversation. So those 2 things are done. That if you have problems with sexual health after your treatment, it's appropriate for you to come here. It's a healthcare issue. And there are resources to help. And 5 and 6, so those are 4 of them. 5 and 6 are probably the most important. And they start with, and you may not care now, because almost everybody doesn't care now. You may not care now, but it's important for you to know. Studies have shown that understanding about it and doing something sooner versus later will make a difference on the outcome.
Great. And tell me a little bit about you creating that 6-point message.
Yeah, it actually came from, we did oncology role plays with simulated patients in these workshops. So we had simulated patients that would sit up front with the nurse that was saying, did you know that cancer and sexual health are related? And the patient would respond, and the healthcare provider would figure out, okay, now what do I do? So what we understood from them was that they really needed to be able to always say something. Not ask questions, but always say something that would give enough information that we could be done in 30 seconds. Or if they wanted more information, we could have them take a brochure home, figure out what their questions are, or set an appointment with an advanced practice provider who could spend that time with them to go into more detail. So everybody can do a 30-second message so that the patient at least knows there's something here. Maybe I want to read about it. Maybe I need to ask some questions about it. Maybe my next appointment I'm going to have some questions when I come back. But at least we have set that expectation with the patient that there is a relationship there and you should know about it.
And as you, what sort of feedback did you get from the nurses and other caregivers that started normalizing this conversation?
You know, the feedback was wonderful because they felt so confident. And what was missing was the confidence that they should talk about this, that they could talk about it, that there were some simple words they could use to do it all the time, and that it would always be appropriate and it would never be inappropriate or offensive. So that, just that information for people, it really just empowered them to, my patients need to know about this. Maybe they don't care about it, but I'm not going to say anything offensive here that would put anybody off. So I tell everybody.
And how has your program, All of Me, which again helps educate those of us in the healthcare industry, how has your program changed from its inception to where it is now?
Yeah, so much, because we started out really just wanting to understand what are the barriers in place to doing this for all patients in all ways. And we put a website together, that's allofmeiowa.org, and that's all getting redesigned right now just for easy navigation. But we developed these workshops from what we learned from our focus groups. These workshops were 4 hours. They were accredited for CEU credits for nursing, and then, of course, social work and therapists as well. And we put on conferences where we highlighted presentations on sexual health and cancer, all sorts of presentations, and we did 3 of them throughout the time that we had grant funding through the Iowa Cancer Consortium. So those, I think we did 9 workshops across the state and had those 3 conferences, and then we ran pilot studies. So we had the assumption that this will work. You will get comfortable with doing this with some training. And so we ran 3 pilot programs throughout the state, and from that, we learned that actually it does work. People do have the confidence to do this once they're given the training of how to do it.
And what would you say would be the minimum amount of training that would get people, nurses, up and running with this 30-second script that helps open the door to a conversation?
Yeah, so depending on where you're planted, if you know you're always going to be talking about this with patients because you're a nurse who's dealing in a gynecology clinic and it's always cervical cancer and you're always going to be talking about it, there is a way to become a sexual health champion just by doing a little bit of the work on your own to learn a lot about this. And that you can find all on the website too, and it's how to become a sexual health champion. But if every cancer center would have a workshop where their people could be trained on that 30-second message and the knowledge that some patients will want to have expectations set beyond that, and some patients will need to be referred out. And those are the 3 parts of the program, is normalizing the conversation, setting expectations, and referring patients out in a timely manner. That can all be done in a half-day workshop. And then, of course, on the website, there will be challenging scenarios. So simulated patients, we did role plays on, a patient breaks down crying, and how could you talk about this? I'm not dealing with this until next year. And all of the challenges that you might find that scare healthcare providers. If somebody's going to break down crying, I'm not going to talk about that. That's going to make her cry. And to get comfortable with those challenging scenarios, what you say. So the site would then have additional information. If you really got involved in wanting to be a sexual health champion, you could pour over that site learning all sorts of things. But really a half-day conference would be a great place for people to start.
And so, Erin, you came to this as a patient. You're not trained as a healthcare worker. Nope. You don't have any credentials as a healthcare worker. When you started putting this together, who did you go to in the healthcare world to help you learn, some of the anatomy, physiology, and resources, so that even as you say, well, you need to be able to refer people out, who did you talk to that would be like the experts that helped guide you in some of the more technical aspects?
There were so many people, it would be hard to even name them, but it was the physicians, it was the advanced practice providers who were having to do that work. They were having to refer patients out. And it was the oncology nurse, but it was going to the individual areas, like understanding a urologist deals with cancer patients for months and years after a cancer diagnosis and after treatment is over because of sexual health issues. So understanding how come, what happens in a prostatectomy, why are there sexual health issues for so many years? So going to the urologist to find out what those are, to the sex therapist or to the mental health therapist to understand what are some of those things that couples still deal with. I thought I knew that, but I didn't know everything. It was just my one experience in the patients that I'd had. But mental health therapists do clue you in. Talking to pelvic floor therapists about what can be done with cancer patients at certain points and what are the symptoms that suggest they need to be referred to.
And so a pelvic floor therapist would be like a physical therapist.
Correct.
Who has some specialized training in the muscles of
That's
the
right.
pelvis that are involved with control of urination, control of defecation, also vaginal and
That's correct for both men and women.
yes.
So all of those places that are working with your cancer patients today, after the cancer is even gone,
And then some gynecologists as well.
gynecologists, urologists, mental health therapists probably are the three most important, the three most obvious places you would go. And the physical therapists probably are as important as any of them.
Where do you think Iowa stands in terms of resources for those physicians who are open to talking about problems, understand and that there are problems, but then looking for, okay, who really is an expert in this field? If I have identified a problem and I want to help the patient get expert care.
So what's nice about Iowa is that Iowa is the first statewide educational program that has been done. The All of Me program was statewide. And it is the only state that's done that so far. But so within Iowa, a lot of people know about the All of Me project, and they would know the resources, where they could get them, that they could come to our website or they could email me about it. But we are trying to move outside of Iowa additionally. Not that Iowa isn't as important, it's just we want to bring more people into this conversation. Mm-hmm. So there are people that do studies on sexual health and cancer, the researchers, and those are, there's studies that are on our website too that really are the science behind all of this, that it is true, it's evidence-based, it's patient-reported. And all of the reasons of why it's all true, and we're trying to bring in as many people to care about the All of Me program, care about getting their own people trained so that they feel comfortable and confident talking to their patients.
And the All of Me website, is that appropriate for both patients and for caregivers?
It is. So it started as a resource for patients, and it's allofmeiowa.org, and the way we've redesigned it is if you are a patient, you go to a place that says, this isn't medical advice, I'm not a physician, talk to your physician about it. So there's a kind of a disclaimer that you go through, and also from the provider side. So there's different places that you go as a patient or a provider. Not that some of that information isn't good for both, but you definitely don't have to weed through the studies and the science as a patient to get some good resource information.
What do you hope in the next 5 years? What do you think All of Me, what would you like to accomplish with the program All of Me, or just generally speaking, how would you like to see American oncology care progress to the point that this is the ideal future state?
So 5 years, time flies, so 5 years is probably going to go too fast, but this needs to be a standard of care, should be a standard of care. It's reasonable, it can be done. it actually all can be done through the All of Me program. In 5 years, if this was standard that a patient would go in for, would have a cancer diagnosis and also be given the information that their cancer will be related to sexual health and how it's related, I would feel like we hit a home run. That's exactly what we want.
You shared with me that some other countries are farther ahead than the United States in terms of having these conversations about sexual health.
Canada is one. They're so close. We could do it like they do. They have, when somebody's diagnosed with cancer there, and for sure in those cancers where they know sexual health will be impacted, they have a sexologist in their cancer clinic that the patients meet with after. I mean, it's all part of the appointment. It's all part of the first appointment. It really normalizes that conversation by suggesting that your sexual health is that important to us. We assume it's that important to you, that we will meet with you right away so that you're given this information right away. And you do with it as you need to. You come back and visit them. Of course, it's different healthcare, it's nationalized, so it's not, we don't have a business model in place for a sexologist to be sitting there talking to you, but in Canada they do. That's all paid for, But really that would be the standard we would hope to get to, that it's that normal for our cancer clinics to think it's that important for patients to have that information.
So, Erin, we're going to open it up to questions, but before we go to questions, is there any information that you haven't imparted to us right now before we go to Q&A?
No, I don't think so. I don't want to make it seem easy, though, that sexual health is just one-dimensional. That I know I said that it's not just sexual function, but so much about intimacy is about sexual health, but it is also about the emotional piece of this. And I think it's important to just acknowledge that patients have so much happen to them with a cancer diagnosis and treatment that their sexual health may be impacted as much by their emotional or psychological impact of all of it. And then relationally, what do I do with that? Where do I connect again with that person who is in some ways a bit removed, lost from us during our treatment? We go through it alone. We have the risk of dying alone. It's us. So we lose that connection with that other person, and to find that connection again, that finding intimacy again, is so complex that there are, I think, a lot of things that patients can do with their partner to get closer to finding that intimacy again. There are exercises you can do, and I mean, there is a slide that talks about emotional intimacy, and the only reason why I want to say this is because if patients are listening, I don't want to gloss over just knowing that your sexual health is impacted is good enough, that things fall apart, and my relationship fell apart. We split up for 3.5 years, and for good reasons. We weren't connected anymore at all, and so I've done a lot of work on what were those pillars that we let erode, because...
Erin, if it's okay with you, let's
Yeah.
bring up the slide about the intimacy and the emotional intimacy, and talk a little bit about that before we open it up to questions. Because I have a feeling that here in this live streaming, and it's going to go, they're probably not going to get a lot of
Keep going.
anatomy and physiology questions, although we might. But
Thank God you're here.
the emotional intimacy, which is part of sexual health.
So keep going, George. One or two more, I think. Well, so this slide just really kind of is just what people assume the definition of intimacy is.
Is the man is
yeah.
sex.
And there is some truth to this in that men are visual and spontaneous, and women really need the foreplay and romance. And so I know that is, that's being too. You can keep going. Oh, there we are. So there is something missing in this too that I have learned in the last year. So we all, to obtain really emotional intimacy within ourselves, so there's something you can do individually too if you're not partnered, but as a partnership, there are these pillars really that hold up emotional intimacy for us. And those individual pillars are different for everybody maybe, but these are pretty common. That communication needs to be one of those values that are something that, underneath communications, the verbal, the nonverbal, the togetherness, the sharing. This was, for me, what I thought was holding us together. And when sex, and it says sex there, but that's too strong, so intercourse stopped. And so really, people have said to me, could you not think of anything else? I mean, why did you let your relationship fall apart because you couldn't have intercourse? In the moment, in the problem, chasing the solution, you aren't able to look at it like that. You're chasing the problem and feverishly finding a solution. You don't really see that gradually you're eroding a bunch of other stuff. Because we couldn't have intercourse, which was our go-to, and it was something that was really important to my partner. Probably not as important to me, if I'm being honest, but it was important to him, and it was a strong connection between us. When that stopped, and I know I didn't get into this, but there's something called sexual scripts, and those scripts are really the launch sequence that goes on between two people launching from a non-sexual situation to a sexual one. So sometimes those things are long, lingering kisses. For us, they were. So a peck on the lips or the cheek is nothing. But if you long, lingering kiss for us was what happened first, and then it would move into a sexual situation. When I could no longer have intercourse, and every time we did, I ended up with blood and tears, or he finally got to the place where he said, I can't do this anymore with the look on your face. I can't be the source of this kind of pain. This is not arousing to me. When we got to that place, we didn't kiss the same. And we didn't because where it led was just depressing. And when we didn't kiss the same, we didn't touch the same either. And that whole leg, that whole physical piece really was eroding underneath us, and we didn't even know it. And it affected our nonverbal, and it affected how often we would take trip together alone. It affected how much I really trusted, and for sure how much he really trusted that I cared. Because I was tired, and I had a lot of fatigue from it. And it was stressful, and I felt bad about it, and I was trying to fix it. All of that impacted probably every part of that. We didn't discuss any of it until after we got back together. When we got back together, what I learned also was that we were in a second marriage. We had a blended family, and we had all these other previous relationships before. You know, you're friends with your friends and your other families and all those relationships you had in the past, and we got by being very independent of each other for happiness. I did my thing. He went golfing with his buddy. None of that was good for us when it came to having this problem, because we could so easily find happiness without each other, and did. It was something that I learned afterwards. If you can't talk to the person you sleep with, you're in trouble. Because we're changing all the time. We're evolving as humans, and so is our relationship. That conversation was so needed. and it was needed on an ongoing basis. So when I talk to patients, it's really start with a clean sheet of paper. Figure out where those legs of your stool are. What are those things? Where are you on that? How are you doing? Could you do that with your partner tonight? Would you know where to start? It'd be really good to start. And if you had to start individually, George, the next slide, just as an individual, emotional intimacy is so important to all of us. It's really all we're looking for. Some people say intimacy is sex, and they find it that way. I would say emotional intimacy for men is achieved a lot of times through physical intimacy, and for women, sometimes just the opposite. But as an individual, you can do this yourself too to determine what are the things that are most important to you. I know I kind of got off on a tangent there, so we can bring it back. But is that what you wanted?
Yeah, no,
okay.
this has been, and I just want to thank you for, being so open, for sharing
Sure.
your story, your vulnerability, and using this to, help others. Yeah. So
Sure.
I think maybe we'll use this as a segue to open it up to questions
Okay.
from our live studio audience, located over here, and from our live streaming audience, where they can write in questions in the chat box. So, questions from our audience. George has a question.
It's hard to ask a question
It's hard to
about
ask a
sex.
question, yes.
Yeah, so I'm interested in the the sexual health element when it comes to the long-term success prognosis of the cancer treatment. I mean, you want to thrive afterwards. You want to survive, and then you want to thrive. And sexual health has a lot to do with that. You don't want to get fatalistic. You don't want to get older than you already are. You want to stay on top of it. And I would think that this would be a big part of not only surviving but thriving after the cancer treatment.
That's a great, and I'm going to broaden that question to say, as individuals get older without even having cancer, sexual dysfunction becomes more apparent and more likely as couples get older, and couples may grow older at different rates. And so the whole idea of sexual intimacy being redefined, especially with the importance of emotional intimacy as individuals age, even without cancer. And what's the parallel? Then you've got cancer is going to be more common as individuals get older. It's definitely more common over the age of 65 than under the age of 65. So you've got these changes that have happened as a result of aging, and then you throw on top of that the cancer diagnosis.
Yes. I think we get a little mixed up in our conversations because we start to use the word sex interchangeably with intimacy, and I don't think they are. So sex for a lot of people is a way to feel intimacy with somebody, but it isn't the only way to feel intimacy with someone. So there's sexual function, and I think that's a good conversation to have, and yes, it does change as we age. So sometimes you can't tell the difference. Is this from my cancer? Is this a side effect, or am I just old? Because both could be true. What's more important than even that, but it's nice to define what can I and what can't I do sexually? What are the limitations that I have in sexual function because of my cancer treatment? So there's that. But everything else is up to me in terms of what I do about intimacy. And it's up to the partnered relationship, how you experience that intimacy. And that's where probably most of the work should be done. And I think that's easier as you get older, too. It's easier for my partner and I to identify emotional intimacy and the importance of touching fingers before you go to sleep at night. Well, that would have never occurred to us as young people. It would have never maybe even been important to us. It means something different now, but recognizing that is part of feeling it too, recognizing that that's intimacy.
Other questions? We got a couple over here.
It's not so much a question, but like I come from a Hispanic family, so we're all huggers. And so, and even with his family, and it was kind of like the hesitation because I had breast cancer. Like, oh, do we hug you? And I'm like, no. So that kind of was weird. And then, so I would come up to my husband and say, let's do a hug. And he's like, okay. And I go, no, give me a really good hug. So it was kind of like, I understand people are walking around eggshells because they don't know what they should say or what they should do.
Sure.
And so for him and I, we had to learn to just, it's okay to hug. It's okay to give a kiss. You know, you're not going to get what I have. And it wasn't that. He was just trying to be careful. So, and then we realized that is part of intimacy. And then part of that change what I was so used to. And then I was asking the question, okay, I had breast cancer, but why is it affecting me in so many ways? And I'm still dealing with side effects from chemo. So,
Sure.
and other things that it's like, wow, this is just a lot to unpack in your brain on this. And what do you say to couples like that when
You know, I think it's great that you would navigate it the way you did, where you felt like you could start that conversation, where I'm a hugger, I want a hug. So every relationship is a little bit different. So not everybody feels the same affection from their partner at the time of a cancer diagnosis than they did the day they were married, right? The relationships, they evolve. So, you know, doesn't stay constant. It's having a voice, recognizing that your relationship probably has changed because of cancer, that you probably do need to rewrite any sexual script you had. If you guys have a pattern of doing something, cancer no doubt interrupted it. If you can just admit that we might need to start over, clean sheet of paper. Really, what interests you about me? What do you find attractive? Or what would you like to do? What would please you? And I don't mean just sexual activity, but I mean emotional intimacy too. I mean both. Starting over, if everybody could start over, knowing that if you've gone through cancer, you need to start over with this sexual script because so many things have changed. I think that's probably what I would advise everybody to assume. Don't assume you got a handle on it or that things haven't changed. Spontaneity changes. It's the number one thing that we don't have anymore as cancer patients. If there's an ostomy or you're taking pain medication there's just so much involved with we're never the same.
So, Erin, I think we have time for one more question.
So I guess a lot of this, I have a lot of personal history, but I have not had good luck finding help. Finding access to pelvic floor specialists, sex therapists that will understand and specialize in what I've gone through. I have had radiation twice. I've had 2 very radical surgeries. I've had cancer 3 times. And some of it's emotional. It's just like, how do I believe that there's still someone out there who's going to accept me for me and love me? And where did my femininity go? And how do I get that back? Where I think a sex therapist would be really helpful, but I don't know how to find one. And I did find one in New York City and was really excited. There was a telehealth set up and it got canceled because they weren't licensed. And New York City is so very, very, very expensive. I can't just fly there once a month.
You know, there are a couple of people in Iowa City that I can refer you to that maybe you could do, even if it wasn't in person. On the website, the allofmeiowa.org, we are trying to put a place where I could list mental health providers in the state that you could go on and watch a 3-minute video, and so could your provider, to see what methodology they use, what kind of patients do they want. Do they want females? Do they want couples? What are their hours? That would be such a great resource for people to have, and sex therapists also, beyond just the mental health therapists.
Dealing with the loss of everything. And for me, I think it's too late for things to be repaired, and I was in a situation where right after the cancer was found, I had a radical hysterectomy. I went into instant menopause, could not take estrogen. Vaguely remember given a set of dilators, not told much about them, but it was the last thing on my mind because I physically felt like crap
Right.
for a very long time.
Oh, I bet you did.
Thank you for sharing your story, and, you know, after we
I
finish
probably
this up, we
shared.
can have a conversation.
Yes, I'll share my email with you.
God bless you.
So our conversation will continue after we bring the show to a close here, but thank you look at how you opened up everybody to talk, to feel comfortable talking about this. So I have a feeling that some of these conversations haven't happened between the doctor and the patient, and you're already making a difference.
Thank you.
So, thank you, Erin, for being with us, and thank all of you for joining us. If you know someone that would benefit by watching, listening to this conversation, it will be available tomorrow on demand at the YouTube channel for Above and Beyond Cancer, and also it'll be available on demand at the Mercy Cancer Center website. Thanks for joining us. I'm Dick Deming, Medical Director, Mercy Cancer Center in Des Moines, and founder of Above and Beyond Cancer. Please join us again next week. Thanks, everybody.